everybody. Dave Rushlow. I serve as the Midwest Department Chair for Family Medicine at Mayo Clinic. This is a snapshot of our department. We have approximately 300 physicians, 250 NPPAs. So we are rapidly approaching a 1-to-1 ratio across our department. We have 75 residents in 4 programs, 60 clinical sites scattered across our region here in Minnesota and Wisconsin. Number of visits for our department per year. I didn't quite get the answer to that one in a timely fashion for the meeting. So suffice it to say, a lot. State laws. It's a pretty open opportunity for NPPAs in Wisconsin and Minnesota. They both can practice independently. However, Mayo Clinic does require collaboration with supervising physicians in all of our clinical areas. They're able to prescribe scheduled medications with a collaboration agreement with a physician. And maybe next slide, Sam. So the models that we use are really quite variable and dependent on multiple different factors that have occurred over the years. So we have NP and PAs working independently and seeing their own panel patients. That occurs certainly in our more rural practices where it's been a bit more challenging to hire physicians, but also occurs in our larger, more urban practices as well. We have what we describe NPPAs as APPs, advanced practice providers, and we have APP clinics, APPs staffing clinics exclusively in urgent care sites and university clinics. Our APPs, unlike physicians, are considered allied health staff. They have their own leadership structure outside of the department structure. They're on a salaried model, although some are working in hourly models as well, such as the urgent care clinics. And next slide, Sam. The collaborating physicians really, for the most part, are not given time, certainly no standardized approach to time given to the collaborating physicians. And frankly, there is the interaction between the APP staff and our physicians it's more informal. Sometimes catch as catch can when needed in a clinical practice. They do have formal education roles in teaching other NPPAs in our practice, as well as helping to teach some of our residents in certain situations and medical students. And what are the major factors that drove these decisions? Well, as I mentioned, a lot of these practice models were developed based on local practice needs over a very long period of time. And you can imagine maybe one of the biggest factors has been maybe the desire to have more of a physician presence or a legacy that a physician had been at a practice and left, and we were unable to replace with a physician, so we replaced with a NPPA, and in many cases that's worked out very well, and it has helped alleviate some real significant staffing shortages over the years. However, maybe in some cases we feel we have overhired, and trying to find that balance, not only of sort of the overall APP MD-DO ratios, but also what is the relationship between APPs, MDs, and DOs? Is it a parallel sort of situation where it's completely up to patient choice with occasional interactions between the two? Or is it to the point where there's a much higher level of supervision and dedicated relationship? And as I think you also know, that a new APP coming into a practice is a much different situation than an APP that's been established and seeing patients over a long period of time. And in many cases, we have many examples of that where a long established APP does function very independently and has a high level of quality, patient satisfaction, and can function in parallel with a physician practice. but the new APP we found is it's much different and does need a great deal of supervision based on the training coming into the role. So I think I'll end it there, Sam.
Great, thanks so much.
Yeah, and what we're going to do is, if you have questions, you can certainly start throwing them in the chat, and Sam will help monitor that. And we'll run through the different models first and then come back for questions.
Great, thanks. Moving on to Michael Jeremiah.
Hey, hello, everybody. For our work we're centered in Roanoke, Virginia, and are affiliated with Virginia Tech for our medical school with Korean Clinic as our health system. And so we are the private clinic and the public partnership has really served us well. We've had a medical school for a little over 10 years. We have 13 residency faculty, more than 150 total physicians, and approximately 80 nurse practitioners and 50 physician assistants. We refer to our colleagues as ACPs. It's a little variation from APPs, so it's advanced clinical practitioners, but same idea. So it's just the way that we group the two together as partners. Number of residents we have is a 30, size total is 30 or 10, 10, 10. We have 55 total clinical sites with the breakdown that you can see. Number of visits is a little over 800,000 per year. So as far as some of the comparative logistics, there is an independent practice pathway for nurse practitioners in Virginia that's relatively new in the last few years. So in the state, yes, we have not endorsed that as part of our system at this point, something we continue to look at and revisit, but that's our current status. And there's not an independent practice pathway for physician assistants. There are no limitations compared to physicians for prescribing. Next slide. So how do we do our models of care? So coverage on or same day access with no panel. Yes, I would say that's the predominant model, is really covering across the practice and between the different panels that are primarily assigned to the physicians. We do have an increasing partnership with our ACPs in our urgent care clinics. So that has been one that we have definitely developed intentionally. Although, again, we do have some interactions very specifically with the physicians, and I'll get to that. Shared panel with attending or resident colleague, yes, that is not true in the majority of our sites, but we have a couple of our larger clinics in which they have a shared panel, and it is a larger panel between a physician and an ACP partner. Independent panel with little or minimal oversight, no, not at this time. So our payment model is for our ACPs, a salary plus a bonus, which is a mix of productivity, and then other value-based components, which are citizenship, quality, and a few others, including scholarship. We also use a sign-on recruitment bonus option. Recruiting has been fiercely competitive for our ACPs, even more than it has for physicians in our area. We have some of our region that has overlap with 4 different systems, and we've seen that really push the salary levels quite high. Next slide. For collaborating physicians, is there payment made for this? There is, and so that is a part of our compensation plan for our physicians, and we are very clear about that, of what the expectations are and how that plays out. Do our ACPs have any educational roles in our department? They do. We had changed to a broad expectation for all of our clinicians to be part of our teaching mission. And so for our physicians, that is primarily to teach medical students. We have 2 other medical schools that are in our region that we work with their medical students primarily, and then we have our own partnership. And then for our nurse practitioners, we ask that they help with nurse practitioner students who need clinical experience, and the same for our physician assistants for PA students. And so they do have those roles. They have other roles as well in terms of some of we have an urgent care and rural fellowship for ACPs, and we have some leaders in that who are ACPs themselves. What were the major factors that drove decisions on how to use ACPs in our department? Just being frank, it's lack of enough physicians, so we had a physician heavy model at the beginning, but it's been, I think, an increasing part of our workforce, and our journey is to add ACPs. Lately, though, I'm kind of at a point where we're actually hiring more physicians than we are at ACPs because of some of the oversight aspects, as well as the ability to handle a large independent panel. And I've had a little bit more success in recruiting physicians. So that's changed the dynamic a little bit. We were on a definite trajectory to add a higher percentage of ACPs over time, but I would say it's kind of stalled and leveled out, and it's about equal right now in terms of the numbers, and then it depends on the site. Next slide.
I think this, yes,
That's
that
it.
was your last slide. Thanks, Michael. Okay, we're moving on to Anna.
Hey, good morning. So we are, the Medical College of Georgia at Augusta University, a state institution. We have 16 faculties, I think 37 residents, 2 clinical sites, approximately about 26,000. I think this has moved up to 28,000. Naturally, compared to the prior 2 presentations, our footprint is smaller. And so, the usage of APP and the count of APP will be, a proportional from that standpoint of view. From a state standpoint of view, we do not have an independent practice for NPs and our PAs or APPs. Sorry. Okay. Are there limitations on prescribing abilities? There are 2 different laws in the state of Georgia that pertain to nurse protocol agreements. APPs in general need to practice in collaboration under the supervision of the physician. They're able to prescribe unscheduled and scheduled medications, again, under the supervision of the physician. Can we have the next slide, please? We predominantly use them for, same day with no panel assignment. And a couple of points that, we can make here. For us, the take-up of APPs was not very active since they were practicing along with residents and faculties. So what we ended up doing was we ended up sharing them with our OB colleagues, and they started going out to our satellite sites. What this has done is naturally the utilization of our APPs has increased, but more than anything is it has given them a new skill sets, or in a very refreshed fashion by sharing them with other services, that they are able to do their role in family medicine probably more, much better. And the other characteristic here is we had hired an APP right out of school. They went to school here in AU, and the first 18 months was more of an education for the APP in question. She was treated more like a 3rd-year resident, probably more of an intern or in a 2nd-year resident, and there was a lot of hand-holding in that exercise. It's more of a salary model. The health system has assumed the responsibility of all the APPs, and so from an employment standpoint of view, they have moved from the university over to the health system. Earlier, it was more of a hybrid model, and they have just inched up the salary because we were not at par. So they have committed to looking at the salary every 6 months. Next slide. For collaborating physician, is there a payment? Yes, they get 10% of the APP's work RVU if they sign off the chart and if they become the attending provider per se. They do not have any educational roles in the department. So for us, the primary reason of why we hired APPs were access. And more than anything, one of the things that we motivated that introduction was our residents, when they go back into the, into private practice or wherever they're going to practice, they will see APPs in their fold. And we wanted to show what it was. There were a lot of learning for us and them because we've never used an APP. This was about 3 years ago. There's some level of friction that we worked through it. But one of the biggest benefit that we had of our APPs during the COVID period was their flexibility. We would have them do telemedicine at a heartbeat, or they would do screening of COVID patients. Because they did not have a panel, right? So they were doing predominantly same day access. So that flexibility was very, very helpful. I'm good.
Thanks, Anna. Okay,
Thank you,
moving
ma'am.
on to our last hunter, Dave Serlin.
Good morning. Thanks, Sam. So I know we have some folks that are on audio only, so I'll read these very quickly, but otherwise for those of you on, you can read them yourselves. But at the University of Michigan Department of Family Medicine, we have about 100 clinical faculty, 13 residents per year, 10 fellowships. We have 17 APPs, 6 clinical sites. We do about 160,000 visits per year and serve 85,000 patients. The state of Michigan doesn't currently have independent practice laws for APPs, although there's legislation proposed and it's floating around in various committees. It's not thought to advance, at least this year. So there's no independent practice currently, nor are there any limitations on prescribing within those supervision responsibilities. Go ahead and advance, please. We primarily use our APPs in coverage of same-day access and urgent care. We don't have standalone urgent care clinics, but within our clinics, they do provide a lot of urgent care. We have a couple of APPs within our group that do maintain an independent panel, but that's not the predominant model we have, and that's mostly based on their skill set. We try to utilize the skill sets of the APPs we have to the best of their ability and put them in places where they can be successful. Our payment model has changed. It's always been a salary model, and it's been through the University of Michigan Medical Group, which is the clinical entity that runs our operations, not the departments or the medical school. In the past, the department would get all of the work RVUs that they generate for shared visits and 10% of the work RVUs from independent and the other category that I'm blanking on, the third category, which is not independent, it's not shared, it's discussed, whatever the word is. In the last year, they've switched that, and now the health system and the medical group are giving us a stipend per APP. So it's a set amount of money per APP to the department in order for us to supervise and credential and do the administrative things we do to support the APPs, which is not particularly advantageous for the department, but we didn't really have much say in that. So go ahead and advance to the next slide. So there is payment now for the supervising or collaborating physicians. We choose to pass on some of that money that the medical group gives to the department onto the physicians for that supervision. The APPs do have educational roles within our department. They teach the medical students in our core family medicine clerkship. So when the students are rotating for us for a month, they work with all the different faculty and residents and the APPs during their clinical time and their clerkship rotation. We also actually have, we used to have 2, now we have 1 APP on our inpatient service. He works with our inpatient team, and I know this is probably more about outpatient and how we utilize them, but we do utilize them pretty extensively on our inpatient service and also with our nursing home rounding team. They're a foundational part of the nursing home group that rounds on nursing home patients. The major factors that drove our decisions and how to use them were, again, access is key, as everyone else has said. We just don't have enough faculty and physicians to manage our patients. And so the APPs let us manage bigger panels. As a separate thing, we're also trying to redo our overall compensation model for our department and moving to a per member per month panel payment within our medical group. And so the larger panels we can manage, the more revenue we will get from our medical group and get away from our views entirely. And that's our overall plan, but I know that gets outside of the particular topic at hand here, but it does go hand in hand. Thank you.
All right. Thanks, guys. And we had worked, the committee had worked to pull those slides together. So we recognize there hopefully will be other questions, that sort of stuff, but we wanted to make sure we all got an overview. I did find it interesting, having read the slides, but now listening to everybody present, the group may or may not have felt the one thing that has moved this forward with us as departments using APPs. There was nobody, correct if I'm wrong, that said we're doing this because it has been shown to provide superior, higher quality care and better patient outcomes. Other than the fact that to everybody, it provides access to our patients, right? But that all of us are struggling within our models to attract enough. I think all of us would say we're struggling to attract enough faculty, and then in our networks to attract enough physicians. So looking through that, I'll throw it open and see if there was one that question from Roger that said, do you bill incident to for APP services, or what is the predominant billing format? At Wake, they do not bill incident to, and I'll throw it to the rest of the group.
Yeah, does anybody bill incident to? Because we're considering it now with we started hiring more APPs because of the competition on MDs and DOs in the Houston market. It's really tough to hire somebody, and the competition is very, very high to hire a family doc for the multiple healthcare systems we have that compete with each other in Houston. But we have a couple of PAs on the private side, about 15 on the public side. The private side, they bill on their own and they have their own panel. Initially, we hired them to see walk-ins and stuff like that, but then eventually they built their own panel. People like them, so they have their own panel. And now we have physicians who have very mature panels, and of course a my chart or desk board full of messages, and they're asking for incident to themselves. So I was wondering if any on the not just the presenters, if you're using incident to, or do you have any problems with that?
So we do not at University of Michigan. And to answer the other question in the chat, we do not require oversight of charting. We choose to do it for shared visits. If the physicians are actually involved in the care, we have the APPs forward those charts to us to review and sign. But for independent visits and directed visits, that's the word I was thinking of, we do not sign those or review those charts on a regular basis.
That's the same for us at Mayo. We don't do incident to billing. Our APPs bill independently. Interestingly, though, you run into these situations like Medicare annual wellness visits where those need to be done by physicians. So we do incident to billing for those with RNs, but we haven't figured out how best to utilize APPs for that.
Yeah,
Roger.
in where we are, we don't use incident to, and primarily the physicians are the ones who bill for the visits.
Roger, we do bill incident to wherever we meet those requirements. It looks like John Coffey down at UF does as well. There may be others. So we have some practices where we only have ACPs at the practice. They're not autonomous. We have an associated physician who's reviewing it and signing charts, but because they're not readily available, then we're not doing the incident billing at those particular sites. But the majority we actually do, and that's worked well for us. The problem is, of course, that a lot of the insurance companies, well, at least Medicare, will reimburse at that 80% aspect, and so it does affect the pro forma as you look at rising salaries for our APP colleagues. And you have a differential in terms of reimbursement that just has to be factored into the business model, obviously. I'll also just mention one other aspect related to what Rich was bringing up. We're taking a close look at the impact of our APPs in regards to referrals, as well as some of the other quality metrics. Some of our folks are absolutely fantastic, and they are good even to teach any of our clinicians throughout the system. But in general, we have started to see a trend of higher referrals and some other issues that are a bit concerning. So we're taking a closer look at that. And I shared with the ADFM committee group on healthcare delivery transformation just a paper that was published out of Mississippi that started to look at some of the differences in quality related from APPs compared to physicians. So it's something to look at. It's a little hard to really tease out, but it is one of those things in terms of your workforce. You want to be able to make sure you're getting a full picture.
And I think the discussion today is to try to help us as a group to start trying to figure out what do we need to do research, Michael, as you're talking about, do we need to figure out what is the right model? I was just at a Pop Health meeting where one model up in your state in Winchester, somebody's promoting 10 APPs to one physician. Yeah, and just sitting basically that the family doc then functions like a preceptor for their whole career. Yeah, with the APPs doing that. And so is that an appropriate model? Does it work? I mean, we're going to have challenges for access, right? As far as how do we meet those? So I think there's definitely some questions there.
So at UF, we have jumped in, we have some APPs who bill on their own, but then to compensate or acknowledge the work of the physicians who do incident 2, we can within our system see who the service provider is versus the billing provider. And so we give the physician 15% of the RVUs generated towards their RVU productivities. We do not, but we also give the APP 100% of the RVUs. So we're not like, taking away from them. And we've worked out some processes to track it appropriately. And that has allowed our physicians feel comfortable then doing incident 2 billing because they're knowing they're getting some RVUs for the supervision or attestation.
And John, I'll just mention ours is similar. We do about 15 to 20% of the RVU equivalents for the physicians who are doing that oversight.
Yeah, I'm gonna throw out a question, just the group for everybody on the typical work week for your APP, ACPs. Is it 8 half days of clinic, 9 half days, 10 half days of clinic, that sort of stuff? Thinking of the ones that are more clinically active, so not faculty.
Our full-time, Rich, is 4.5 days or 36 hours, and then 4 hours for clinical administrative time to kind of catch up. That's similar for both physicians as well as for our APPs. Interestingly, though, new applicants are absolutely looking for only 4 days a week in the office and being paid full-time. And that's a real challenge for us right now.
Yeah. I don't know, Dave or anybody else.
For us at Mayo, we are at 32 and 8, what we call visit care, 32 hours of visit care, 8 hours of non-visit care to do the in-basket work and documentation. And that's both physicians and APPs, and it can be spread across 4 or 5 days, however it works best for that clinical site.
Yeah.
So David, I was wondering who was busting the curve for the rest of us. So now I know. So thank you.
We're the same. We're the same as Dave just mentioned. And we also have them, we expect them to work some non-traditional hours also in rotation with the physician. So some evenings, Saturdays, along with our faculty.
Right.
We could do an entire hour on the 32 and 8, and that would be actually a great topic. I'd love to talk about.
Okay, Dave, we can put that on for another hot topic. Sam's writing it down, but yeah. So, Michael, we can just blame our Midwestern colleagues.
Yeah, for us it's also 32/8, but we started with 36 and 4, but then we and the chair at the time brought them down by 4 hours. So for any scholarly efforts, so anyone whom we are going to hire will be 36 and 4. So Rich, don't worry about it. The South will be South.
Okay, yeah, and I just want to point out, Dave pointed out, and Serlin pointed out an important piece in the chat that his NPs are unionized and the PAs are becoming unionized. Dave, you were saying?
Just became unionized last year.
Okay.
So that adds an extra layer of complexity to these hours and expectations and what we can hold them accountable for and metrics and things like that. So it's very much in flux, especially for our PAs right now, since they just unionized in the past year.
Right. And Katrina asked, as far as for those that have an independent panel, what's the typical panel size that's expected for an APP? I can say in our Wake Forest Health Network, within the department, we don't use them. We use them more, as many folks are for access. In the network, if they're running their own panel, typically we're thinking what we've said is somewhere between 750 and 800 individuals, which is part of the problem. When Michael was talking about if you a family doc, we expect 1850. So many of our family docs are not making what 2 APPs together are making to get to that panel. So I don't know, other folks, do you have panel sizes for those who have independent panels?
Yeah, for us, we risk adjust our panel size
Mhm.
to ACC scores. And for an APP, that's 1250. And for physicians, it's 2200. And for shared panels, there's a bit of an ongoing conversation, but we're looking at the 32 to 3500. Now that number is not, it's a hard thing to compare to actual souls, if it's just people. But it actually helps us because we have obviously big differences in complexity across the department or across our sites.
Yeah. So Dave, there's another one to go along with how do you risk adjust your panel, right? Yeah, that there's 1,000 different ways of doing that along with your work week.
Hey, Rich, I know we have
Rich.
ongoing commentary just about the 32.8. I think that as a follow-up, that would be an interesting one because I think it also matches what comp you're using. So it could be you're trading off more of that, kind of balance and throughout the week, but then you may not be paying the same level of compensation you were for 36.4. So just another takeaway that we might want to explore.
Yeah.
So Rich, I'll just jump in here. So
Yeah, Valerie, go ahead. Yeah.
we at UW have very similar to what our compatriots on either side, Michigan and Mayo, have. We have a couple of areas that I'd like other people's comments on too. So one is none of our APPs are considered primary care physician or primary care providers, as we say. And that's been an ongoing area because a lot of our APPs would like to be primary care providers and have a panel. As it is, they tend to do same day urgent care. The challenge with that is they're often seeing our sickest patients. And so it's the same day urgent care that gets turned around, sent to the ED or has to be acutely managed. And we're trying to think about and look at that because some of them would be just great for doing the well visits kind of thing. That segmentation of practice, we haven't done. So Dave Serling, you talked about your model, and as you know, we're all on panel and have been for quite a while, and we have a weighted panel. So what's happened with an APP is a group like a practice will get so much compensation based on the cumulative panel for the number of people there. And then if you add APPs, what that does is it comes out of the panel to provide support, not total, for the APPs. Now, the challenge with that, I can understand that from a health system perspective, but the challenge with it is the docs say, well, I don't want another APP because that'll just reduce my comp because it cuts into the panel compensation for the office. So psychologically, I probably wouldn't go there. We're dealing with trying to change it or think about other models now. And then the final thing is we did a study, and part of our study was asking patients about their team and who they considered on their primary healthcare team. And they did not, by and large, even though they would give me an example of seeing somebody, an APP, they did not recognize that person as part of the primary care team. And in fact, everything that they would see by and large went through the primary care physician. So even though we have some great APPs, that's something we're struggling with, is how to have our patients know who they're seeing, even beyond the APPs. So those I'll throw out as comments and questions.
And I will say we lean heavily on Val and in the University of Wisconsin and sort of developing our panel sizes way back. And so we have not made that a part of our compensation plan at all, but we do use it for setting panel sizes and use those APPs in a similar way, but without the compensation consequences, because we just haven't gotten there yet with the compensation side.
Thanks, Val. And I want to, Jennifer, you had said, can you repeat those numbers? Were you needing, and I'm sorry, I'm trying to see it on the Hollywood Squares. Were you needing the repeat of the numbers that Dave Rushlow gave for Mayo?
Yeah, I wrote down 2,200 for faculty and then I couldn't write fast enough.
Okay.
Oh, yeah, for APPs, it's 1,250. And for physicians, it's 2,200. And for a shared panel is in discussion right now. In order to make the staffing numbers work, it really needs to be combined, and we have examples of that. But we're also getting some pushback that just going to what would be a 3,450 or 3,500 would be too much.
Could I ask a question about how you all are getting exact panel sizes? Are you using a specific marker in your EMR, like a certain designation in the patient's chart that says who exactly is their provider?
Yeah, for us, it's a pretty clear expectation that there's a PCP provided to each panel or each patient. Now, Epic will only allow one name, so we struggle a little bit with shared panels, whose name,
Right.
but we've stated it's the physician's name for the shared panel.
And so if you, for example, if you were hiring an APP because you had, I'll just give an example. So we had 3 physicians retire in the last 2 years. Their combined patient load was somewhere like around 4,000. So we've been trying to hire APPs, right, just to keep access available for these people. So we probably still have 2,000 of those patients who are now assigned to people who don't work here anymore. Like, does anyone have workflow for how they're transitioning those patients to APP panels to try to help understand what the exact assignment is?
So here in Augusta, we attempted to do that, but we did not. We tried to stratify based on severity and risk, age group, and we want to say if they were younger, between 30 to 40, and they've only been seen, once or twice in the last 24 months, they could go to the APP for follow-up care. But it became very convoluted, during the process. But we realized there can be a method to madness, but but a couple of things need to fall in place. Happy to share the model later if you would like, at least talk through it.
Great, thanks.
Just an FYI, it's the way that your Epic is set up, because we also have Epic at the University of Rochester. And you can put in there CCP, which is a continuity of care provider. And there's that can be separate from the PCP. And they just basically, it's CCP first, PCP second. So that's used for physician's assistants, nurse practitioners, as well as our residents. So that's actually how your Epic is being set up, not that it's not an option.
Tracy, we use a variation of that. We're an Epic shop as well, and we have a general PCP field. We have a resident PCP field, and we have an ACP or APP PCP field. And just to give that kind of continuity, what we're trying to do though is we've done our quality tracking across the general PCP field, and I really want to get to more specifics on the quality tracking for our APP partners. And so that's more of our internal IT wrestling, but I'd be curious, are others being able to track and give that specific quality feedback to their APPs?
So at UF, we track each patient who is seen by the provider, and it kind of rolls up into a monthly report for the quality side. And then as far as assignment, rather than going by who is listed as the primary care provider, we created an in-house report that looks at how many patients, who saw which patient over the last 18 months, or we can pick whatever time period. We use 18 months. And then from there, we look to see as if a patient saw one provider 4 times, but someone else once, then we assign them to that provider that they saw 4 times for purposes of analyzing panel sizes and things like that. Does that make sense?
It does. That's what we're doing at Wake.
Yeah, it's so kind of that plurality of interactions so that you can really align it. And it does make sense. Of course, we're not, having independent panels for APPs, and that if you do, then that's easier way to do it. But when you have that cross cover model, I was curious about how that was done. So thanks, John.
Yeah, and then Laura in the chat, and then let's see, had talked about that she's been doing some piloting work with portal messages, looking at sort of what bugs a lot of folks is they go home, right? We're all sitting here and we go home and we have 21 portal messages to deal with. And so actually using APPs to help manage some of that and turning them into virtual visits, which can be helpful, particularly if you're in a state. North Carolina, still, we haven't expanded Medicaid. We still have not gone for parity for telehealth. We're moving right along with not helping out with some of the stuff. But if you have that available, and then it was that, is it Rochester said they've been doing something similar? So there's some folks that are looking at, can they rotate and use folks a little bit differently, our APP colleagues with that. And then I will say it's interesting, the comment as far as wanting a panel. All of our APPs in our department, NPs and PAs, have worked somewhere else before they came to us. None of them wanted a patient panel because they know what comes with a patient panel as far as the phone messages, the inbox, all that stuff. They have loved doing more of the supportive care in a module. We have 4 of them, one in each module, that they are the same day pop-off valve. And some days they're busy, some days they're not. They can help out with that. And Val, to your point, you're absolutely right. You can have the sicker one. So you have to be sure that people are available to consult, and that your physicians that are in those practices are willing to pick up those really sick patients, right? Because otherwise you do end up with more emergency room, more things for those patients that may be necessary.
No, Rich, I think that was an excellent point. If we had, if we need to start all over again, we will start with not having a panel for our APPs. We ran into a situation where the patient was very comfortable with the APP, did not want to go anywhere else, but the complexity of care was too much for her to take care of, and it became a very tricky situation.
Yep. Yeah, I'm going up today in 12:30. I've got a patient that saw one of the APPs that he really wanted to come back in because he's blind, diabetic, neuropathy, all kinds of stuff that he just said, to your point on it, it's a little bit much. Do you mind taking a look at it today? So within that, but you have to make sure you have that culture, right? If we have a culture of you need to function, there are many institutions. I don't think in the academic departments, we're not hearing it, but in the health systems, where they're hiring APPs to be a complete substitute, not a complement to what we do in primary care, but substituting for physicians. And that oftentimes doesn't feel great to them after they've been in it for a little bit. So
one other brief point about the attribution models we were talking about a minute ago is it's important, I think, to consider what the floor or the end date is. So Epic has, I'm listed as a PCP for patients I haven't seen in 10 years and are out of state and have moved away and maybe not alive for all I know. So, insurance companies look at a new patient being if you haven't seen them in 3 years. That was our original attribution, is that they would stay attributed for up to 3 years. Our health system wanted to move that down to 18 months. We pushed, and it was a visit-based attribution. We pushed back and said, okay, you can't have visit-based then. It's got to be any contact in this day and age and with COVID. So now it can include a visit, a phone call, a medication refill, a lab order or result, a portal message from them to us, like not me sending them a message. If they don't reply, that doesn't count, but them initiating some sort of contact with us maintains that attribution.
Sure. Yeah, because a healthy individual that just needs their eye drops refilled, that just had their pap smear last year, was completely normal. We may not necessarily need to bring them in, Dave. That's interesting that you're using all those different touch points, which is,
and since we're being paid now per member per month, it's important for us as a department to maintain those attributions appropriately, because that's our payment model now.
Yeah, well, I think you should get paid for that person you hadn't seen in 10 years, right? Yeah,
absolutely.
Okay, let's see. And then, has anyone transitioned their APPs from having their own panel of patients to working as more as a support to a physician team? So flipping it. So somebody that went back from panel back now to I don't have a panel.
Yeah, I think we did that. And we had a lot of happy campers when we did that, honestly. They felt that it was getting overwhelmed, especially in a teaching enterprise where the complexity of patients were, much more than what they were trained for. So that's why they say, you know what, I'll be more than happy to be a support, be same days and also be used in other services if I need to.
I think that's a great question. And I would say we've had the reaction. We are also trying to move to a shared panel model because actually we did an analysis and found that for those that had shared panels, we were seeing high performance. And this topic has been very, very contentious. And it really kind of depends. There are several of our APP colleagues who are very adamant about maintaining an independent practice. And so even bringing up the topic of a shared panel has been difficult. And then there are others that do welcome it. And our approach has been, let's try this and then measure it. Because we think we're not moving wholesale to it. But we're also thinking that this could be an opportunity to help reduce burnout, as we've talked about. We got to get the panel sizes right, which is a huge question. And we need to make sure that we're using everybody at the top of their licensure, because what I'm concerned about is if you go too far in one direction and you end up with parallel practices, then, what's the difference? And of course, we all know there is a difference. So the importance is trying to define that, and while being respectful of the value that each of these, these professionals bring.
Dave, can I follow up on that and just ask you, since you gave us those specific numbers, which I think was helpful in terms of expected panel size for an APP versus a physician, and some of this aspect of how they manage panels, does that proportion between the panel size roughly reflect the difference in compensation?
Oh, good question. I think it does. I think it does. When you look at the there was no intent on having it work out that way, but as I think about compensation for physicians and for APPs, it does work out because it's roughly half, but not maybe quite so. Reality is that we have some APPs that have very high over panels, but in general, our APPs are less close to the goal, if this makes sense, than our physicians, or our physicians are more likely to be overpaneled than our APPs when they're strictly subject to patient preference. Same for fill rates. Generally our physicians have higher fill rates than APPs.
And then there was a question earlier, I apologize, that just saw it back, was just about particular, we've kind of touched a little bit, but onboarding practices. So if we bring let's say for a new APP, if we bring a new APP in our department, the first 6 months, they're acting kind of like, I think you were describing, they were acting like an intern. They present every patient to one of our preceptors when they're physically in the department because of the complexity we have. And then we have gotten to know them and we turn them loose and we collaboratively do that. What do other folks do if you're bringing a new APP on, somebody straight out of practice? I mean, out of school, excuse me.
Yeah, I think it's really difficult. The complexity of primary care and family medicine in particular is one of the most difficult places. It's not just training them to do like one specific procedure or one specific disease process. Yeah. So I don't think we quite have 6 months, Rich, for us, but it's probably a good 2 or 3 months of shadowing, then, seeing patients independently, but presenting each one, and then a graduated program until they're more independent. But it's probably more like 3 months for us.
Okay.
Rich, we're doing similarly. I guess the other challenge, though, has been during the pandemic that a lot of learners have not had the same clinical exposure. And so we're seeing it in our residents, we're seeing it in our APPs, and it's a particular concern. And so we're really trying to pay attention to that and do a more robust orientation, both in terms of what we're covering, but also the duration of time.
So, Rich, we've been similar, but we haven't got it so well organized. We have moved to only hiring APPs with experience, if possible. And the ones that are inexperienced, which are rare, one of the physicians is assigned as a preceptor. it's not as rigorous as we do even for our residents. So we're continuing to work on that.
Yeah, well, the reason I was bringing it up is that, and I was saying new specifically, as I'm hearing, as I talk to other colleagues in other areas, everybody only wants to hire APPs with experience, right? So I don't want them hiring out of my department after I provided it. We're also seeing a resurgence, at least in our area, we're going to call them fellowships or PA residencies and these sorts of things. And that just is delaying them going out into practice. So we're extending, which could make the workforce issues more difficult than if we're able to develop within our areas. How do we, there is that investment of bringing them up to speed. So that's important. So, and then Joe Gary he's getting right to the chase. So he's asking, knowing that there's regional differences, what are we paying? So, so we got to make sure. I mean, I don't think we'll hit antitrust and get in trouble if we share our salaries because we're in different areas of the country. Typically at Wake, we're benchmarked, and it's a little bit difficult because our APPs are working 8 half days a week. And if they keep pushing through salary increases, but a starting, so if you talk about a new, this was 5 to 8 years in, 5 to 8 years in, typically would be in the 120 to 130 range. I don't know if other folks want 5 to 8 years was the question, if I'm getting it right.
Yeah, Rich,
CBA, and we're about the same. So we use MGMA. I go into the MGMA data dive, and that's how we benchmark our APP compensation.
I was just going to comment too. I think Sarah and I compete in part of our regions together, and it drives it up along with a couple of other competitors in that area. But it has risen, especially those who have experience. I'd say that's the rough ballpark for us as well. For somebody who's not coming in with that experience, it would be lower. But it's changed. I mean, it's really changed a lot in the last 5 years. And when we had nurses doing travel, kind of compensation in this past year, who were making up to, a lot more than that, $100 an hour, getting up to $200,000 a year equivalent or more. That really upset all kinds of benchmarks, and some of that has settled back down, as we know. But it certainly has affected this, and it's not going down. It continues to climb up.
I will say that I'm so sorry to interject again, but we've lost several candidates because the competing salary offers they were getting from outside of academic medicine were upwards of 150 for very similar jobs. They practice independently in our practices, but different compensation for the same job, essentially.
Yeah. So what we have done here is probably we had to recalibrate all the salaries because everyone were all over the shop and we were not competitive. So the health system did do a compensation survey. So 5 to 8 years, Rich, it's, for us, it's 110, you guys are much more than us. 10K, hopefully, they don't pick that up,
I'll send it out, Anna. I'm sending it down. So
yeah, right. But anyways, but what is very interesting about this exercise was they've given a good, transparency by saying that if you are in the particular year block, it means 5 to 8 years, you'll be on a 110. If you're 8 to 10, you'll increase by $5,000, and they have made it automatic so that everyone knows where they're going to land, so that there's no, two thoughts about, where the salary can be.
Rich, just another comment, because I think this is a really good topic. Some of the schools for particularly nurse practitioners we have seen where faculty are coaching them to expect, they're looking at medians and looking at benchmarks, and they're saying, I want to make median or higher. And we have this conversation over and over again. It's like, if everybody makes median when they come out, it is no longer median.
Right.
It's a simple math thing, but it's amazing how that goes. And that's why I asked David about how this might correlate with panel size management, with hours, with expected scope, because it becomes a business model that you have to really look at, and to say, if the salary and compensation keep rising, what is the expectation and the ability of our APP colleagues to meet that? Because otherwise it starts to invert a bit, and you have some questions about sustaining it.
Right. Well, and as all the salaries keep going, I don't know about you guys, but and Michael likes to give me a hard time about Blue Cross Blue Shield in North Carolina, how good they are to us, but they are not paying us any more for anything we're doing this year, even though salaries have risen. for for the APPs, everything else, the work the payment I get for doing whatever I'm doing in the office and the faculty are doing hasn't changed. And so at some point, those pressures, you can't keep running everything through with that. So that's great. Dave, I don't know, or Dave or David, if you guys, y'all maybe since your state, Dave, in Michigan, you may not be able to share, you can get in trouble, but with I know for you, it's unionized, right? So you've got
It
the
is.
union issue. Yeah.
And I actually don't know. I haven't even read through the whole union contract since we don't
Okay.
hire them and we don't pay them. I haven't paid that much
Okay.
attention. I don't have numbers to give. Sorry.
Okay, no, that's
Yeah, and
sorry,
I am less familiar actually with our APP because they're in the allied health staff and it's a whole different structure. But I would guess, back to Michael's question, they're slightly higher than half of our physician practice, and it's market based. And so it isn't, there is no productivity variability to the APP salary here either. Whereas we do have a portion of the compensation for physicians tied to, productivity and quality and that type of thing. They're completely separate.
So
Yeah.
for us,
Go ahead.
Richard, it's about the same as the salaries that have been mentioned. And our APPs are not the same across the domain, so that our APP on the inpatient services that work atypical hours or not 9 to 5 get paid more than the outpatient APPs that work kind of a 9 to 5. And also we have a separate group that acts as geriatric nurse practitioners that work the most independently they do have a panel of geriatric patients that they share with the family physician in nursing homes. So there is some variability in those two groups in the hospital, and the geriatric nurse practitioners would earn more.
Yeah, and I do want to acknowledge Linda Spear had put in that some skilled APPs or PAs are just as productive as the physicians, and they carry panel. Yeah, so I think hopefully as we get close to the hour and people need to sign off, that hopefully you can take away from this that there is no one perfect model that we saw from each folks. It seems like access was a common theme, that we got to get access, because if our patients can't get access to us, then that's a problem. We've talked about some of the payment issues and some of the quality. Michael's going to come back and inform us about what he's learned about all the quality stuff within this and with that. But this is going to be something we're going to be needing to look forward down the road to kind of define as the population ages, as we're trying to do this work. How do we do it? The other piece I appreciate that folks said, one of the issues I think Anna, he had to sign off, put in was for education. That's part of what we did, is we realized, 7 years ago when I became chair, we didn't have APPs. We had APP faculty that would be here a half day a week from the PA school so they could do their clinical stuff. We didn't have them in the department where our residents and med students learned what they do in primary care. And so they do, I think, Dave, you were saying they rotate in those things. So the educational component. So hopefully this was helpful. I've got 12 o'clock and I want to be respectful of folks' time. Sam was going to send out the slides again if you didn't get them. And we'll go from there. We have another hot topic, and we're trying to get these things on about a quarterly basis for everybody. So appreciate your time, and thanks, Dave, Anna, who's not on, and Michael for pulling this together and presenting today. Thanks, everybody.
For moderating, masterful moderating as always.
Yeah.
Thanks, everybody.
Y'all have a great day.
Thanks, everyone.